Hi folks, welcome to our last online lesson for medications to treat GI problems. These are our objectives, and our medication list, as usual, is only representative of the meds we're going to take a look at today. I have a Prezi created, a mountain man story about Mount Gerd. And so at any point, you don't have to do it right now, but at any point this week, you will take a look at the Prezi about GERD. And it's a mountain man story. This is actually a picture of my nephew on the far left with his buddies who run an outfit crew out of Wyoming. So I'm going to talk now about nausea and vomiting and kind of the treatments that we can offer patients for that. Of course, you know nausea and vomiting are simply symptoms. There's myriad etiologies. We are going to think about treating the symptom of vomiting while we work up for an underlying cause in most cases. In terms of underlying causes, that can be anything from anxiety to a GERD situation where someone is starting to have some vomiting. It can be a viral gastroenteritis, which is one of the most common causes of nausea and vomiting. It can be pregnancy. A number of causes are out there. So, of course, that workup is multifactorial. I'm going to ask you to think about and contrast two drugs, ondansetron versus meclizine, which are kind of two drug types that are represented for this problem, and what you do and don't like about their side effect and adverse reaction profile, their efficacy, and then I would have said in the past cost, because it used to be that ondansetron was prohibitively expensive, but it came off patent a year ago, and we now have it on a $4 list, so that's not a problem. First drug is ondansetron, and it's a selective 5-HT3 type serotonin receptor antagonist. And here we have serotonin again. It's a major player in so many things, and the gut is definitely one of them. So serotonin receptors are present peripherally and centrally. And we're not sure whether this drug works centrally, peripherally, or at both sites. Honestly, it probably doesn't matter, but it's really a great drug. It is almost a miracle drug. It was developed initially and approved first for the use with chemotherapy patients, and it's really changed the face of chemotherapy and the ability to withstand the intense nausea and vomiting that goes with those treatments. It's got a fairly modest side effect profile, some headache, fatigue, a little constipation. Some people have diarrhea. Rarely EPS comes through. It is contraindicated in first trimester pregnancy, although there is mixed data. The jury is still out on that. But at this point, not recommended for general practice. I'm sure that some specialists, when they have a person who has severe nausea and vomiting of first trimester pregnancy, are probably prescribing it, understanding that there is some risk, but the benefit would outweigh that in terms of the safety and viability of the fetus, and of course the mother as well. Then we have an older drug, a way older drug, an old antihistamine, and meclizine, which is a kissing cousin to our hydroxyzine. It's also known as Dramamine or Bonine. It's over the counter. It's an H1 or a histamine 1 receptor antagonist. It is an anticholinergic drug, and thus its effect. It's also used for vertigo quite a bit. It depresses the labyrinth excitability and vestibular stimulation, and it may affect the medullary chemoreceptor trigger zone. It's also a mild dopamine antagonist, but that effect doesn't really play out in this drug. Its side effect profile, of course, is anticholinergic with drowsiness, dry mouth, constipation, urinary retention being the key ones. And of course, that a little star should be next to urinary retention, especially in elders, because we want to be careful of that with them. And we think of our elderly males with prostatic hypertrophy already kind of closing off that outlet and thinking that they might have problems. Now, keep in mind that drugs like this actually can sometimes be used for their side effect to help with urine leakage and urine excess urination, but we wouldn't really want to use that in this case as a primary drug. So, good anti-nauseas. Also, not really listed here. Well, yes, listed here, but the drowsiness and kind of that somnolence goes with this one, so we want to be careful. So switching gears and the other end of the spectrum, the other end of the bowel, the scourge of elders and toddlers too, constipation. And specifically when we think of elders and I'll talk about toddlers in a second, but elders, you know, really it's much a functional problem in most cases. It's usually gradual onset, and our elders, of course, have lower levels of physical activity, lower fiber intake often in their diet, and then we also have lower fluid intake, whether it's because they're afraid that they're going to have to pee more often, or if they are simply losing their thirst sensation, which is pretty common in elders to have that happen. On the other end of the spectrum, functionally, the toddler tends to have a very low residue diet, you know, preferring things like mac and cheese, drinking milk, and they might have plenty of fluid going on, but they certainly are moving around, but their diet is pretty low residue. In their case, they may also have some behavioral issues in terms of stool retention, not wanting to go poop on the potty and things like that. So we see kind of two pictures at the two ends of the age spectrum. Of course, there are red flags. Sudden onset of constipation at any age may mean that there's some kind of obstruction. We certainly want to be aware of any abdominal pain, fever going on. So there's workups that can be done. And if we convince ourselves that we have a functional situation, we get into the medications. And medications, your book does a nice job of kind of lining those out, are kind of divided into three main categories in terms of stimulants, bulking agents, and stool softeners. Our stimulants, of course, work by getting that bowel wall to actually move, thus the term bowel movement, and are absolutely mandatory for our patients with spinal cord injury or spinal cord impairment, neurologic impairment. So many of our stroke patients, etc., sometimes as well. So we may need a stimulant in some cases. Bulking agents, of course, just put artificial fiber or bulk into the stool. We do prefer actual dietary fiber, but these agents can work, and they increase the bulk of the stool, thus causing stimulation to occur of the bowel wall and thus the muscle contraction, and they bring more water into the stool. Stool softeners just bring water into the stool without bulking. They are things like Colace, and they there's an old nursing adage, you don't want to just give the mush without the push. So there are cases when the stool softener can be helpful if people have adequate pushing going on in terms of the constriction. Our goals of treatment, of course, are functional. There is no such thing as a normal bowel pattern. A bowel movement every 5 days is just as normal as 5 bowel movements in 1 day. Of course, the downside of treatment is causing iatrogenic diarrhea or problems that way. We also see that occasionally there is abuse of laxatives by persons who might be wishing to expel more feces, those with eating disorders and disordered body image sometimes get into trouble that way. Non-pharm, of course, is very important in treatment of constipation, and those would be strategies such as increasing the activity, increasing fluids, increasing fiber, and in all age groups, really scheduling time for bowel movement. And we, of course, see in our elder population in nursing homes that nurses and nursing assistants know all about this, making sure that the person actually gets to a toilet and is encouraged to have a bowel movement at a regular time each day. Toddlers, this is very effective as well. And even with some populations, special populations like our severely mentally ill, who might be institutionalized, might be having trouble with disorganized thinking or mania, and might be need to be encouraged to have a regular time for a bowel movement and actually sit them down on the toilet. And those strategies are very helpful. This is a great resource. This article you can link on below in the slide set. Takes you to an article about getting adequate fiber in the diet. The most useful column on this is these second two columns where you look at the number of grams per calories per day that are required. Now keep in mind that there are very few of us adults who are going to be on 1,000 calories a day of diet. So you need to do the math and increase the amount of fiber that we need in our older ages. Also pregnancy and lactation, look how high those go up for females. And it's per 1,000. So if you're taking in 1,500 calories, you're going to need to multiply that by 1.5 for the number of grams of fiber. And if you take a look at some of the packages of particularly prepared foods and look at the amount of fiber, it's really small. So getting enough fiber every day is a major challenge. With any fiber supplementation, whether it's dietary or by use of medications that are fiber supplements, we want to be sure to move fairly slowly, since fiber will, if added quickly to the diet, will cause a lot of bloating and gas. Now, switching gears, and I'm just going to walk through these cases here at the end of this slide set. The other end of the spectrum, of course, is diarrhea. And I'm just going to quickly walk through these cases. So we have a 75-year-old who's tachycardic, low-grade fever. Now, the tachycardia is telling us they probably have a fever, as we recall. Watery stools every hour for 24 hours, and you can imagine that this person is probably fairly dehydrated. So in this case, this is probably infectious based on the fact that they're febrile. They're having a lot of watery stools. They're probably going to need IV hydration, rehydration in this case. We probably don't want to give them any thing to stop the diarrhea artificially, but simply let it work its way through with good support, and they will need IV rehydration. A 40-year-old female who does not have fever, does not look sick, doesn't have any evidence of infection, but has anxiety that causes diarrhea, might well be a candidate for some medications for diarrhea. A 15-month-old male who's febrile, vomiting, diarrhea for 24 hours, but he's had a wet diaper in the last few hours, so we're thinking he's maintaining hydration. You know, babies and small children will drink even if they vomit, and if you give them sips of something like Pedialyte, they will absorb enough water to stay hydrated. We'll probably hold on his antidiarrheal medication as well. The 35-year-old with food poisoning, we might give them some medication. Again, they're not infectious. We might wait 24 hours to see if we could get most of the food poisoning out of their system, but then they might be a good candidate for some antidiarrheal medication. I'm going to stop there, and we will be touching upon these medications in the next slide set about IBS.